presenting his MSc thesis proposal on a very interesting and challenging preference topic. Wait, Peter.
Thank you. Apologies for the delay this morning. We're just trying to get one of the committee members in on the line, but I think I'll sort it out. Thanks for giving me the opportunity to speak and for attending today. As a quick overview, I'll just give a little bit of background on cochlear implantation and describe some limitations of the currently available instruments that we have for listening utilities in those people. And then I'll move on to describe my proposed methods for the thesis, which will involve identifying concepts that impact hearing-related quality of life, redesigning the hearing attribute of the HUI3, and then assessing its face and content validity. And I hope to get some discussion around strengths and feedbacks of my proposed work. So firstly, cochlear implants take acoustic signal from the outside environment and translate it into an electric signal, which is then translated down into an electrode, which is implanted on the inner ear hearing organ called the cochlea. And that transmits an electrical signal into the brain, which we perceive as sound. Essentially, we bypass all of the existing instrument for translating acoustic energy into electric energy. And traditionally, we've been giving individuals who have bilateral impairment just one implant to restore their hearing, but we're increasingly recognizing the benefits of giving people two implants. And those benefits can be recognized objectively in tests that we can do in the clinic where we see that people have a better understanding of speech in complex environments like noisy environments, and they can localize sound better. And those benefits are borne out in qualitative reports, and as well, there's some other benefits that we see, like the security of redundancy, the feeling that individual feels safe having a second implant in case one of them fails, and improved quality of sound, things like music enjoyment of environmental sounds, and then other sort of more anecdotal evidence around reduced effort required to listen and focus, increased social confidence. As far as measured health-related quality of life, there are a number of condition-specific measures that have demonstrated an improvement in bilateral over unilateral users. SSQ, or speech spatial quality scales, is one of the most commonly used ones, but there are a huge number of other ones that have also demonstrated a significant improvement in their overall scores for bilateral users. Similarly, in generic measures like SF36, we see some improvement in social functioning and mental health subscales. Now, of course, the other way to quantify health-related quality of life is to use preference-based measures. These, as many of you know, conceptualize health on a scale between dead and perfect health, sometimes worse than dead. And if that scale has interval properties, we can use it to calculate quality-adjusted life years for use in economic analyses. But also, maybe equally importantly, having that single measure of health-related quality of life can be very helpful in other circumstances like clinical decision-making as a trial outcome measure on its own, particularly in conditions where preference is hugely important, like in hearing impairment. We can measure that through direct methods, which involve comparing the health state of interest to other health states with kind of defined utility values. Or more efficiently and more commonly, we use indirect measurements using preference-based measures of health-related quality of life. Okay, so preference-based measures have two major components, one being the health state classification system, and these conceptualize health according to a number of attributes, and they ask individuals to classify their own health according to those attributes within levels, according to levels within those attributes. And then the second component being a utility value scoring function, which outputs utility associated with the defined health state. Looking at utility values that have been listed in bilateral implant users, a number of different strategies have been tried, both indirect and direct methods. EQ5D, the Euroqual 5-dimension, is one of the more commonly used ones, but the most commonly used one is the HUI3, and that's probably at least in part due to its inclusion of the hearing attribute in the conceptualization of health. May have some content advantage over the other indirect measures. And the ability of that hearing attribute to change the overall quality of life as measured by utility is quite substantial. If you take, for example, an individual who is unable to hear at all and is otherwise perfectly healthy, which is actually not an uncommon scenario in people who receive cochlear implants. Their overall health utility is 0.465. A lot of you recognize that as being fairly low utility. And despite that range of potential change in health-related quality of life because of hearing, if you look at the difference between bilateral and unilateral users, the overall utility value is actually quite insignificantly different. These are repeated measure studies that show the difference between the unilateral and bilateral state about a year after bilateral implantation, and the overall health utility difference is about 0.01. And looking at other indirect measures, you'll see that the differences are similarly small and inconsistent. So trying to get at why, with this huge potential range, we're not seeing a big difference. So looking more critically at the hearing attribute, you'll notice that there are really only 2 levels in that hearing attribute that apply to cochlear implant users. And that's because all the other levels that apply to people who can who hear anything whatsoever require those individuals to hear in a circumstance where they don't have a hearing aid at all, which is very uncommon for cochlear implant users. And so really all we're discriminating people on here is whether or not they can hear what's said in a group conversation with 3 other people. And if we look just at those 2 hearing-related states, we can see that the overall difference in utility is about 0.21, and with a clinically important difference on that overall utility scale of 0.03, there's certainly potential for there to be a lot of intervening levels that are clinically important hearing-related states. Further, if we apply some comorbidities to those patients, so it kind of reduces or attenuates the overall effect of hearing, the difference is still pretty substantial at 0.16, with several intervals of clinically important differences. And importantly, it's not only the difference between these 2, but also there may be potential for hearing states that aren't defined that are slightly worse than level 5 or slightly better than level 3 that we're not capturing for the bilateral users. And this issue of having a generic measure that's not quite sensitive enough to discriminate in important health states in a particular condition is not new to cochlear implants, or not unique to cochlear implants, and I'm sure not unfamiliar to a lot of people here. And there have been a number of solutions to try to address that issue. The first I'll talk about is mapping or crosswalking. And that involves taking a non-preference-based condition-specific measure as maybe one of the examples of many that we've seen are significantly different in unilateral and bilateral users, and mapping those on using a mapping function to a generic preference-based measure. The criticism with that is that it really relies on a degree of overlap between the 2 instruments to have a good performance of that algorithm. The second strategy being bolt-on, which is to add additional attributes to the generic measure. The issue with this approach is that well, firstly, you're changing the measurement properties of that instrument, so you'll have to recheck all of those, and also may require reevaluation of the whole instrument, which is a huge amount of work, and therefore a lot of people have turned to just starting from scratch and generating their own condition-specific preference-based measure. The issue with this approach is that there might be some compromised specificity for other health states. If you take some of the attributes and dedicate them towards your condition of interest, you have to borrow them from somewhere else, and you might be missing some important other health states, like important comorbidities or side effects of the treatment you're looking at. And also there are some effects related to the valuation of that, where it emphasizes the importance of the condition you're looking at just because of the focus of the instrument. So we're sort of in a relatively unique circumstance here, where we have a very popular generic preference-based measure in the HUI3 that has a hearing attribute, and that is really dedicated towards the population of interest. And so what we're proposing is a kind of a previously undescribed approach, which is to, instead of generating a new instrument or adding a new attribute, to modify the existing attribute that is the hearing-related functioning. And we know from all of the clinical evidence that there are a number of different components to hearing that people find important with respect to functioning. And so hearing might better be represented by a sort of multi-sub-attribute approach to describing the hearing-related functioning of an individual. These are just examples of some things that might be important. And with that, we would estimate a new single attribute utility function that would be a function of these sub-attributes, which would then be used in the calculation of the overall health state utility value, and replacing the existing single attribute function. So with the aim then of improving the discrimination and responsiveness of the HUI3 for health states related to unilateral and bilateral implants, I'm trying to accomplish that in three objectives. The first being to identify concepts that affect the hearing-related quality of life of cochlear implant users, and then to redesign the hearing attribute of the HUI3 according to those concepts that we identified in Objective 1. And lastly, to evaluate the sensitivity of that, the sensibility of that redesigned health state classification system as a whole for patients with cochlear implants. So just an overarching overview here to show exactly where we are in the development of a whole instrument. It involves several phases. The first being the derivation of a new sub-attribute hearing state classification system, and the second being the sensibility assessment. After that, it would require the re-estimation of a new single attribute utility function, and lastly, to evaluate the measurement properties of that new instrument. And for this master's thesis, I'm going to propose that I finish after phase 2, leaving phase 3 or 4 for future work. So in order to identify important concepts, I'm going to be looking primarily at 3 sources, the first being literature, the next expert focus groups, and lastly with key informant interviews with patients. As new concepts and items emerge, I'll initially classify them according to the WHO ICF framework for functioning disability and health. But as new attributes become apparent, then we'll start splitting out the clinically different attributes. Systematic review will look at all published studies that have reported on condition-specific instruments and look at those items and domains, particularly those that perform well in discrimination of unilateral and bilateral users. We'll also look at all the qualitative work that was done in the generation of those instruments to try to identify items and attributes that might be relevant to our population. And as those come out, as I mentioned, I'll be attempting to organize them according to attributes that have common themes. And we'll really use the focus groups as a means of validating that classification scheme. So then I'll move on to an expert focus group. It'll be composed of cochlear implant surgeons and audiologists who manage cochlear implant patients kind of after surgery, and the potential for social workers or psychologists who have experience treating patients with hearing impairment. And with that group, I'll present the literature-generated list and encourage, obviously, the contribution of new attributes and items that aren't included, but also to help separate attributes that contain disparate items or combine ones that we feel are the same. And with that information, move on to key informant interviews with patients. There's obviously some advantage to the group environment of a focus group, but it's a bit challenging with individuals with hearing impairment, so we'll do it on a one-on-one basis. And I'll recruit individuals according to a stratified sample with about 20 unilateral users and 20 bilateral users, with emphasis on the kind of traditional unilateral candidate, which is someone who has a cochlear implant in one ear and really not a meaningfully usable function in the other ear. And emphasis from the bilateral group will be on the quote-unquote traditional bilateral user, which is CI's cochlear implants on both sides. The key informant interviews will have 3 main objectives. Objective A will be to generate additional items. So before presenting them with the literature generated list, I'll ask general questions about their health-related quality of life, and in a semi-structured format, then focus the conversation around attributes that I've already generated and the range of functionality associated with those attributes. And I'll also use that opportunity to generate importance scores for all of the attributes and items that we've generated. This has been previously described in other condition-specific preference-based measures, where I'll ask them to rate the importance to their health-related quality of life of each item and attribute according to a 7-point scale. And lastly, for the patient interviews, I'll ask them to give me an idea of the functional relative improvement in scores. If you recall, one of the objectives of this is to differentiate unilateral and bilateral users. Unfortunately, there's a population of people who have had experience with both unilateral and bilateral users who happen to be the kind of majority of the adult bilateral users. And we'll ask them to compare their functional ability within each of the items and attributes compared to when they had one implant. So with that generated large amount of information, I'll move on to the redesigning the new hearing attribute, and that will be accomplished in 2 steps. First, some item reduction, and then the level descriptions and structuring. For the sub-attribute item reduction, we will first try to maintain structural independence. So there's going to be a number of items that come up that might be addressed either explicitly or implicitly by other attributes of the existing HUI3 and their associated levels. So according to consensus judgment, we'll do our best to discard ones that we feel are addressed by other attributes. The HUI3 was developed with this sort of within the skin philosophy, whereby social interactions are not explicitly described within the classification system, but instead they're described according to the functions that mediate those interactions, like the senses, communication, listening, vision. And so we'll try to maintain that philosophy in the generation of our modified instrument. And we'll aim to minimize the cognitive burden of filling out the instruments. It probably won't end up being 8 attributes, but that's sort of the top end that we'll permit just because of the size of the existing instrument. And we will combine items and domains with conceptual overlap and validate those combinations with a face validity assessment with patients in a following section. And after item reduction, we'll move on to descriptions and structuring. We're trying to here as best we can to mirror the structure of the existing HUI3. And the HUI3 really describes its levels, and here's the example of the vision attribute with a few items per level. And what I mean by that is best illustrated with an example. So if I look at the vision attribute, it's asking patients whether or not they can read ordinary newspaper, newsprint, whether they can recognize a friend on the other side of the street, and whether or not they need glasses. So that'd be an example of a 3-item attribute. So then we'll use the importance scores and the relative functional improvement scores we generated to decide on the most important attributes and the most important items to include. And we'll allow maximum of 7 levels per attribute according to the amount of information that people can comfortably process. And then lastly, once we have a draft of the redesigned hearing health state classification system, I'll move on to some semi-structured interviews with patients to assess the sensibility, primarily be interested here in whether or not they feel it's comprehensive and relevant to their current health state, whether or not all the questions are clear, the wording is clear, and then we'll present to them the domains and items that we collapse into one and make sure that they approve of those suggestions, and then also offer the opportunity for them to give additional suggestions or additional items or domains that we may have missed. After final adjustments, we'll represent it to the expert focus group, really with the same sorts of questions, just to make sure that we have decent face validity. In terms of feasibility for the project, I don't anticipate the accrual time for patients to be longer than about a month, given the volume at Sunnybrook Health Sciences Center. I have some funding support from a departmental initiative as well from a Sunnybrook grant, which should cover most of the necessary additional expenses, including research assistant salary. And the timeline, I've already submitted an ethics proposal to Sunnybrook. As soon as that's back, I'll submit to U of T. I've begun the literature review and done most of the screening. And I hope to I'll have a dedicated time in my second year to dedicate to this project with no course load. So that's all I have. Welcome your feedback.
Yes.
Yes.
Great. And so is that, maybe I didn't understand correctly, but is that, is there going to be a new version of the hearing, or is this going to be aiming to replace the hearing component of the hearing? Are you thinking of using it for just like the hearing is right now, but replacing the hearing component, or like it's one step towards the new hearing?
Good question. So really the instrument is going to be designed, and the whole focus of the design is around cochlear implant users. So that's the population that will design it for and initially use it for, with the intention that if you were using it in other populations, would use the HUI3 as it is designed now. So that's not to say that in the future, other patients with hearing impairment, there might be some other populations which we might decide to try to validate the instrument in. So to better classify other patients with other degrees of hearing impairment. I think even if we generate it for cochlear implant users specifically, if we make the wording amenable to other patients with hearing aids or with other hearing-related conditions, my assumption is that it will do a better job than the current HUI.
Okay,
yeah.
So what do you think is the ethical consequence of that on vision patients? I mean, having a more sensitive instrument on cochlear implant would maybe likely have a result that seems that it's more cost effective to have cochlear implantation. Mm-hmm. But what would a vision patient say about that?
Well, I can't speak for, I mean, other vision patients. I don't have a clinical experience with vision patients, obviously, and I don't think it's just, if you go out and you do a cost effectiveness study and you demonstrate cost effectiveness in your population, you've done all this work and you've used whatever data that you do, and you do a well-designed project, I don't know if you necessarily feel bad for the patients who you haven't done that effectiveness study on. I'm not saying I don't feel bad for the other patients, but I'm just saying that I don't think it's necessarily my responsibility to be, concerned about other generation of other instruments, at this time. Okay.
Hi, nice presentation, nice project. Quick question about the composition of your focus group. You said that patients won't be included in the focus, you will do the interviews with them, that's fine. What about informal caregivers? One of the big piece for hearing impairment, patients suffering from hearing impairment is also burden on the people they live with, right? So their partners, their kids. So it might be good to think about, when you do the focus groups, to maybe include their, I call them informal caregivers. They are not. They are partners, either husbands, wives, mm-hmm. or children. Because I have a student of mine in one of the courses that I teach with a hearing impairment, and he has cochlear implant, bilateral. And he explained, even now, I have a special microphone and everything when I teach for him and for the class to use that special equipment. That being said, he said that actually using an improvement in cochlear implants had significant impact on his relationships. So that's why I'm just kind of thinking about maybe including partners, yes, or children in the focus groups. I understand why you can't have patients maybe, involved, and you will have them separately as interviewing them, but maybe have, or at least think about when you are interviewing patients, interview also the partners.
Yeah, I think that's a great suggestion to get a little bit more information qualitatively about, what is impacting the quality of life of patients. I do think, though, that there are kind of two separate questions. One is, overall, like the quality of life of an individual with hearing impairment, what are the major impacts, and then what are the health-related quality of life impacts as it relates to the generation of a new HUI3 instrument, which is a slightly different question. But I agree, there might be some valuable information from caregivers. Yeah.
So just following up on that question, we had this discussion yesterday, like we were talking on the phone with Dr. Feeney, and the HUI does not have a big focus on social interrelationships. It's a little bit different than some of the other indirect preference instruments that do. And I guess what I'm wondering is whether you think social interactions fall within the domain of health. Like, is that health or not? And is that an important component of hearing? Like, it may be, for example, that the actual function with respect to sound localization and these more sort of directly hearing-related dimensions may not be so different, but it may be that the biggest change is related to how people relate to their significant others and people in their families. And if that's the case, are we going to have the capacity to detect that effect?
Well, I think that just because it isn't explicitly described that, that there's a social interaction component within the instrument doesn't mean that we can't capture that effect looking at specific functions. I mean, that effect is mediated by our ability to hear and by maybe the unsightliness of an implant or by the self-confidence with respect to social interaction, which I think we can capture with kind of excluding the social component. I can't say whether or not I completely agree or disagree with not including social interactions at all in the instrument, but that is in keeping with the HUI3 and the way it was designed and conceptualized. So I think disrupting that might have broader implications that we're not.
No, like for sure. I mean, if we made already the choice to go with the HUI3, then you sort of have to live with that. I just am wondering what the implications of that choice will be, given that this is potentially a very major component of the incremental benefit of bilateral relative to unilateral.
Yeah.
I just want to say something. I enjoy listening to you talk about caregivers and spouses, and we're extremely sensitive to that. And in fact, we wrote a paper on that particular topic not too long ago. But this is a very individual-based preference, right? And then patients are asked to assess themselves. Another component of benefit is a benefit to society and taxation, for example. When patients become more productive, if they earn more income and pay more taxes, then you can also say, well, why should all the other taxpayers also chime in on this particular issue of improvement?
Well, they actually, shouldn't be answering we should be asking him questions.
No, sorry.
Peter, yes. Do the taxpayers weigh in on the HUI3?
Yes. So in terms of the HUI3 and a lot of other instruments, actually, the preference weights that are generated by the instrument are actually by taxpayers themselves. In a sense, the HUI3 is generated with utility weights from members of the Ontario population in Hamilton. So I guess in a sense they do contribute to the generation of the instrument. But I think the question more broadly is whether or not we should be considering the costs. I mean, really, the overarching purpose of all of this is to look at the cost effectiveness of bilateral implantation. And traditionally we often ignore the indirect implications of cost, and Dr. Chen might be suggesting that might be a very big component of the cost associated with cochlear implants, and thing that we might need to reconsider.
Just add another question, Peter. Currently, is there an age limit with regards to how this is used on patient population? Is it adult only, or can we bring it down to a lower age group?
So it has been used in children, and most oftentimes when it is used in children, it's used by proxy respondent, so a parent filling it out on behalf of the child. I'm not aware specifically of hearing impairment of any actual child filling out the survey, what's the lower limit of that age. I do recall a study that included patients as young as 16, but whether or not it's lower than that by self-report, I'm not sure.
So as an extension to that previous comment, wouldn't that bias this preference?
Absolutely.
The caregiver burden?
And they did a validation study when they actually did the generation of the HUI3 using Ontario Health Survey data. They compared the responses from proxy respondents in a household compared to the individual responses, and found that they were quite disparate. So they recognize that as a limitation of the instrument. Yeah.
Yes, this is really interesting. And as you know, I'm creating another instrument. So your title was to improve the discrimination and responsiveness of the HUI3. And I know that you're doing measurement properties in your fourth stage beyond your thesis. But how are you going to optimize discrimination and responsiveness in the design of your questions in your focus groups for clinicians and patients?
Yeah, that's a good question. So one of the big components of the method that we're going to be using to select items and attributes will be those relative improvement scores that we discussed. So specifically looking at the individuals who've had one cochlear implant, they spent some time with one cochlear implant, being accustomed to it and learning the functional abilities and disabilities associated with it, and later received a second, and then have lived for a period of time afterwards. So those are probably the best people for us to be asking about what the relative improvements in health-related quality of life and functioning are. So we'll use information from those people and quantify as best as we can according to a Likert scale. So the relative improvement of each item and attribute, use that information in the generation of the item, instrument in order to improve responsiveness. With a small population, as you know, there's huge variability in utility values. So it might be more challenging to assess the kind of discrimination on an individual basis, but we'll use that kind of long-term responsiveness as a proxy for that.
So you said something earlier on, I guess all the questions relate to what happens later, steps 3 and 4. You said that maybe states that are worse than big will be deaf. I think you said that.
What I meant, not, sorry, states worse than deaf, but states worse than 3 and 5. So,
sorry, not deaf, but deaf.
Yes, deaf. I don't think within the current instrument we'll capture states that are worse than deaf because of the way that the overall multi-attribute function was derived.
You showed us the five levels of the current HUI, hearing, unable to hear at all. So we talked about this briefly last week. You're hoping to develop sort of several attribute utility function to generate utility between 0 and 1.
Yes.
Which you will slot into the current utility scores generated by this.
Yeah.
Which I think is fine so long as 0 is the worst and 1 is the best for that similar attribute utility. If you have, I'm not sure what it would be, maybe you'll get items from respondents. It turns out, there are things worse than not being able to, I'm not sure what this would be, but it's like, what is unable to hear at all? Having a lot of like ringing in your ears all the time or something, that might be problematic if you got, then it'd be hard to slot this new scale in. It's not the same, there's not the same anchors anymore.
Yeah.
And so that may, that's a problem for the future, but it's just something I wondered if.
Yeah, absolutely. And like I said, problem for future, it's something that we really only find out empirically by trying to, because if you organize the states and you assume that there might be nothing worse than unable to hear at all, in the evaluation process, you might give people the opportunity to identify their own order of states and find that one's worse. But I think that in the generation of the instrument, most of the hearing-related functioning that we're talking about is going to be almost objectively better than unable to hear at all. You're right, there might be some circumstances where they have some pain associated with it or some other infection process. So my hope is that that will be captured by the other attributes of the instrument. So to hopefully mitigate that.
One of them, just a general
Very
question.
good point. I mean, we've actually thought about that more in terms of the upper anchor rather than the lower anchor, but that's a very good thought. I mean, it won't affect the overall structure of the instrument because the magnitude of hearing is still going to be preserved, but you're right, the scale anchors are potentially a problem.
Yeah.
And it's a less sophisticated point. So the whole point is just when you have the items, you said you're going to have to rank them on a Likert scale. Like very important to not important.
Yeah.
I guess when I see that, I worry that if people rate everything as being important, if nobody distinguish between them. Have you thought about ranking them rather than just rating them?
I have thought about ranking rather than rating, but I wonder when there's a huge, depending on the number of items and attributes that we generate, it might become a very cognitively burdensome process for people to rank them. And I think that the ranking might have actually less discriminative ability than just rating it.
The problem is that not every respondent sees the same question. As the interviews go on, sometimes attributes get added. So
That's another good point. Yeah.
Ranks can kind of change. Okay, so I think we're going to let you go, all of you except for those who are on the committee or faculty who will have to stay behind and think deep thoughts for a few moments. We'll excuse Peter and thank you for listening.